Hello, everyone, and welcome to the Medical Fitness Podcast. I'm Jeff Young, and in this episode, we have two physical therapists and a physical therapist assistant being interviewed by my co host, Dr. Thomas Hammett. Podcast is brought to you by the Medicine Rehab and Fitness Institute and JY Kinesiology LLC, both of which are dedicated to medical fitness education and building the bridge between medicine, rehab, and fitness. You can learn more at mrfinstitute.org. The purpose of our podcast is to provide you with principle and evidence-based content on all things related to exercise science, strength and conditioning, medical fitness, and building the bridge between medicine, rehab, and fitness. The purpose of this podcast is to share with you a unique case study, a story about how these clinicians transitioned from a traditional PT setting to successfully integrating fitness and nutrition components into the overall plan of care. They talk about some bumps in the road during the transition stage and how they now fully understand this lifestyle medicine based model of care. This is an approach that should be the standard protocol for all private practice facilities and is successful not only from a patient care perspective, but also a revenue perspective. I hope you enjoy the conversation as much as I did. Let's get started. All right. Hey, everyone. Welcome again to the next episode of the Medical Fitness Podcast. And we have a really good one today that I'm excited for because we have my co-host, Dr. Thomas Hammett, and some physical therapists and a physical therapist assistant. So I'm actually going to pass this over to my co-host, Thomas, because they are colleagues of his in Seattle, Washington, and he has some questions prepared. So Thomas, you can go ahead and take over and we'll go from there.
Thanks, Jeff. Yeah, I'm really excited to have three familiar faces on the other side of the screen today, or on the other side of the audio if you're tuning in via audio. So in November of 2019, I started to work with a clinic in just south of Seattle in a suburb called Lakeland Hills of Auburn. And the goal in this clinic was to bring a more collaborative care model to an existing physical therapy group. So a group of therapists that were already practicing in this clinic that really the company itself decided, okay, we want to try this different model of care. The CEO was interested in it. So how can we make this thing work? And I got involved in working with the therapists and the exercise staff to start to make that transition happen. So I'm really excited. Over the past 3.5 years now, we have gotten to work a lot together. My goal today is just to share kind of a case study for any listeners out there who are interested in what this can look like in a real life physical therapy context. So I'm excited to introduce Brandy Eloff is a clinic director and physical therapist. Haley Hooper is a physical therapist as well, and Jessica French, who's a PTA. Unfortunately, Pat is not with us right now. She may surprise us and hop in a little bit, but we're going with the clinical staff today, and I think it's exciting to get the clinical side of this model explained to us too. So before I do much more introduction of you guys, do you mind just introducing yourselves and kind of like your role beyond anything else that I've said so far in the clinic?
Well, I'm Brandy. I am, yes, I'm the clinic director and physical therapist. So I oversee the entire clinic, including our wellness director, who Thomas alluded to is Pat. And also we have a dietitian on staff. So I kind of manage the entire clinic and operations of this lifestyle medicine model.
Sweet. Okay. And then Haley and Jessica, do you mind just like saying hi so the people know what your voices are?
Hi. Hi, I'm Haley. I'm the other physical therapist.
I'm Jessica. I'm the PTA.
Awesome. Okay. So before we start, like I kind of explained a little bit that this model is different than what you used to practice, right? Like before November 2019, you guys were doing something. And then in November 2019, we made a commitment, we're doing something else. Can you guys explain maybe in your own words what that change was to you? Maybe start with Brandy.
Okay. Yeah, so it was presented as an opportunity to practice differently, and we didn't really know what that meant at the time. said, we're going to change our practice model. You're going to have a wellness director. You're going to have dietetics offered in clinic. You're going to go through this training, and then you're kind of not going to be on your own, but we're kind of expected to sort of make this work and figure out how this is going to work. And of course, we had a lot of ongoing support from Thomas. But what we found after we had gone through some training was, at least for me, the biggest change was how we were evaluating our patients on that first visit. And how much further really we were looking into their medical history. We all kind of review it on some level, like, oh, they have diabetes and they have high blood pressure and they have, X number of other things. You document it, you move on. And that was pretty much what we were doing before. We're aware of it. There's not much we can do about it. So we're just going to treat whatever they're coming in for. So this sort of changed my mind shift from how else can we help this patient? Because a lot of the time they come back to see us because of those other comorbidities. They have diabetes, so they don't heal well. Well, are they managing their diabetes? And so it kind of opened the door to having different conversations with our patients. And it's, smoking cessation, sleep health, stress levels, things like that. So that took extra time, which was a really hard thing for us to do initially, was feel like this was something extra that we were doing, and it was taking, quote unquote PT time. And it felt like something separate, but really, I think over time, it has really just been now what I view as PT and not just wellness, I guess.
That's great. Haley and Jessica, what do you have anything you want to add to that in terms of how the change affected you?
I think I appreciated a little bit more on the patient care side of things, because patients are really excited that we care about treating them as a whole, and it's not just treating them as their injury of what they're coming in for. And I think they get really excited about that, and that makes me excited as well. So I appreciate that.
I agree with Brandy. I think when we first heard about the change, it was in little tidbits. So it was, you're going to practice differently, and you're going to have these new staff members, and things are going to change for you. But learning the practice model and being able to implement the practice model just changes the way that you treat patients. It changes the way that you see their injuries. It changes the way that you see their healing times. It changes the discussions that you have with the patient around the comorbidities that Brandy was talking about, diabetes, hypertension, hypothyroidism, in terms of tissue healing and patient expectations. So I think, it makes expectations more realistic for me and expectations more realistic for the patient, and has been helpful in talking about prognosis, which is something that patients always ask about.
Yeah, I love what you guys are saying. I like the way that you describe it. It feels like such a no-brainer, right? Of course therapy's like that, right? Of course we consider that stuff. And yet I think what maybe is different is the way, the how we do it, right? And Brandy, you alluded to, well, there were some changes. Of course we added some new staff members in the clinic, but then there were some things that you had to do that felt like extra time at first. And I'm curious, I'd love for you to explain a little bit so that listeners can try to picture what's different about your practice model versus maybe what you were doing before, to get an idea what that extra stuff was.
Mm-hmm. So at the initial evaluation, we spend about, well, it depends, 8 to 15 minutes really going over vital signs, which we all learned in school. I don't know how many people actually do it when we get out into practice, but actually taking vital signs, asking about their activity levels, asking about smoking history. So a little bit further in depth than just their orthopedic history. And also, I guess it includes our in-body scale. So that gives us a sense of muscle mass, which is important for our population that may have osteopenia or osteoporosis. So that spending that time, the first visit, to just get those measurements and to really talk about that in more depth versus, again, just scanning the medical history chart they filled out and probably didn't answer very honestly or correctly. And then at the second visit, their follow-up visit, we compile all of that information into a packet, and we educate the patient about what we found and why is that even important to what they're coming to us for. So, you hear a lot of, I'm here for my knee. Why does my diabetes matter? And then opening that conversation. So on a basic, I hope that answers your question, but on a basic level, that's what that is.
Yeah, Jessica, Haley, maybe for you guys, what if there's anything you want to add in terms of process in the clinic that felt different, like how you guys do this that's different than the way you used to do it before?
Yeah, I think I agree with Brandy that just talking about vitals and seeing why that's important, and also giving us an idea of, we're looking to see, is this person at risk for developing metabolic disorder, which is going to lead to other potentially catastrophic comorbidities in terms of heart attack, stroke, things like that. So being able to screen for that at that initial visit, find out what is your risk, and now having people in clinic that can help us address those things appropriately. I think that is the biggest difference. So, okay, yes, I've identified it. Yes, this can potentially be a big problem for you, not only in terms of your tissue healing and for your musculoskeletal disorder, but just for your life in general, and being able to do something about it. Okay, well, I have a dietitian that can help you with A, B, and C, and I have someone who can help you on the exercise side of things to address A, B, and C. So I think that process has been a little bit different, not only identifying it, but being able to do something about it.
That's great. Yeah. So my image now between kind of like the difference between where you transition to is that, all right, so before we were taking vitals, but now we're really taking vitals with intent and doing something with that information and with the medical history that's different than just, maybe saying, okay, well, I'm going to like maybe exercise with this person a little bit differently in PT so I don't mess with their blood pressure and, have a major issue. But we're taking that and having a conversation every time with our clients about their health, about their just general health and lifestyle goals beyond therapy as well. And then when appropriate, incorporating these other providers that exist within the clinic or other, services that might be helpful to your patients into the therapy care plan. Great. Mm-hmm. And then when appropriate, those patients of yours eventually, whether it's during PT or afterwards, end up working with those other providers.
Yeah.
Yeah.
Great. It seems like you guys, and a couple of you have alluded to this already, but it seems like you were maybe a little bit skeptical about this change when it was rolled out. Brandy, even yesterday when I was talking with her about this conversation, she was like, yeah, we were voluntold that we were going to do this process. And, talking to you now, I know that that's changed, that you're not skeptical, that it's not something that you're like trying to fit into your mind of like, why are we doing this? And I'm curious when that changed for you, or what led to this like belief in the model of care rather than one of skepticism.
For me, it probably took the first couple of years, to be honest, to really make that big, or to have that mind shift change. I think it happened as a result of just seeing, first trusting the staff that we had to carry out the interventions we were recommending. So we went through some iterations of who that right person was. And once we got that person on board, we really saw what it could be. And I'm talking about the exercise piece in particular. For me, I think I kept seeing patients for the same injury over and over and over, and it would be like every 6 months or every year. And those are the people that I haven't really seen back for the same thing since we've had these other services available. It would be hard for me to actually go back and figure out somebody. So they're making longer term behavior changes, which are great. And I just wasn't sure how well that would actually work in practice. I think, I'm trying to think of when did this mind shift happen? I guess I think for me, again, it was just the trust in the providers and seeing what they actually brought to the table and how they could help our patients. And then also, as Haley mentioned earlier, I think my expectations from what my patients would achieve in therapy were better aligned when I started to look at the whole picture a little bit better. So if they had something that might delay tissue healing, I wasn't assuming that that person would get better in the same period of time as someone who did not. And that also helped align the patient's expectations. And then if you run out of PT visits, then you have somebody there who can kind of help extend your care and they don't just get cut off. So
I have a quick question. So you mentioned trust,
Mhm.
you know, and obviously since I'm a fitness professional, I'm interested from the exercise piece. You know, if you could just like briefly explain what do you mean by the trust? Was it trust because of patient feedback? Was it trust because what you visually saw? Was it trust because of maybe some in-services going on and that, or, you know, was it a combination of the above? I'm really curious about that.
It was a combination of feedback from patients, and then also what we were seeing in the clinic at the time. So we have, you know, a certified exercise physiologist. She's very well trained, and the people before her theoretically were as well. But some of the cueing, some of that supervision, exercise progression, it's just a lot of it was patient feedback, to be honest, of how much attention was given to what was happening, and how they felt things were going. So Haley might have more to add to that.
Yeah, I would say too, just patient feedback definitely, but also just seeing how we're talking about Pat in particular, how Pat interacts with the patients and how she opens up conversations that, you know, maybe we haven't thought to open up in PT just because of our differences in knowledge. And having that open line of communication between the therapy staff and Pat, our exercise physiologist, I think being open with communication, having her give us feedback, like this patient's really struggling with A, B, and C. You know, I'm going to address it this way. If you can also address it on the PT side of things, I think that they would also benefit from that. So I really think that it's her knowledge and expertise and her interaction with patients that has helped me trust her with my patients. You know, PTs, we see patients as ours. So, you know, trust her with my patients essentially, and know that if I send people over to her, they're going to get a next level care that a traditional PT patient may not necessarily get.
Had you worked with an exercise specialist before previously so that you had points of reference, or was this the first?
This was a first. So we were learning what an exercise physiologist expertise should be, what that should look like. And that's kind of what took us a while, not having that experience of knowing what to expect. And it's like any other position, right? There's great PTs, there's some that aren't or they're not a good fit, right? So it took us a while to find the right fit. Yeah, I would say.
I think this would actually be a really good time for any of you guys, whoever wants to own this, to explain what the services are that the fitness professional offers in your clinic, because you guys did, prior to moving into this model, have exercise techs. And, you know, and the language used in physical therapy clinics, I have a friend who works on the East Coast, and an exercise specialist is a tech. And when we use that language, it can be unclear when it's in a PT clinic. It'd be really helpful if you guys can share, like, what does an ES do now compared to what they used to do, maybe, or what a tech does in your model of care and in this clinic.
Like the differences between the tech and the exercise physiologist. I'll keep it clear. Yeah.
Yep.
Okay. So what we call our techs are just our care extenders. They do not have any autonomy with treatment. They don't perform treatment. They're going to take you through some of your range of motion exercises, the things we don't feel need to be supervised by a PT or by another licensed professional. Exercise physiologist is somebody that we trust to either change exercises, program new exercises, address different body parts, because they have been trained to do that for people with injury. And so they have a more knowledge base on how to do that safely.
And then maybe Haley, if you can tap in and just explain, like, is it like a set of services that Pat offers, or what does that look like? Is it like one-on-one sessions, or how does she do the work that she does in this model?
By the way, most people looking for the services of a fitness professional are really just looking for information on how to get started on the right path, not to pay for training sessions every week for months or years on end. For the 60 to 70% of people with chronic disease and or joint pain, they're also looking for someone who can help them develop a clinically safe, individualized exercise program that takes their conditions into consideration. If you're interested in getting yourself, or for clinicians, your patients, started on a safe, cost-friendly medical fitness program, you can find more information about the virtual services we offer at mrfinstitute.org/services. We staff only degreed kinesiologists and exercise physiologists and will work with your healthcare providers in the design of your exercise program. For the clinicians listening in, you can add this virtual service as a reduced cost option for your patients. Check out our website and send us an email, and we'll give you the details about this unique and much needed service.
Yeah, so there's a couple of different options, which works nicely with PT. So we have one option that we call Bridge, and it's basically a bridge from PT back to, whatever the patient's goals are. So that is for patients that are currently being treated within a plan of care for PT. And that can either be to work on, like Brandy said, another body part, like maybe they're coming in complaining about their shoulder and their hip and their knee. But the shoulder is the primary concern. So we're addressing the shoulder in PT. And then they can go and see Pat, our exercise physiologist, to address hip pain, if we don't feel like it may require a full PT assessment at that time. They can also work within the same plan of care. So if I have a patient, we'll say shoulder pain, that doesn't need a whole lot of manual therapy and just needs a lot of guidance and motor control, stability, overhead stability, and they're working back towards whether it's something specific or just in general, they want to be able to lift overhead, or they want to be able to carry their kid up the stairs, and they can't do that because there's some kind of motor control or strength deficit that's causing them pain with that activity. We'll do once a week in PT and once a week with this bridge appointment, where they get 30 minutes one-on-one with the exercise physiologist. And so they work within the PT plan of care. If the goal is motor control, then they get guided motor control activities, but we leave that up to her. So she's got the knowledge and expertise, more so than we get in PT school, regarding appropriate exercise progression in terms of load and those kinds of things. So we can work together. So that's Bridge. We can also use it as, you're kind of phasing out of PT, but we don't quite want to discharge you, or a traditional discharge. You're not done. So maybe we've reached our goals on the PT side of things. We transition them to what we call lifestyle conditioning. And that's the same. It's a 30-minute one-on-one session with Pat. It could be 30 minutes or 60 minutes, but they're no longer a PT patient. So you're kind of done with PT. Either you've run out of visits, or we've kind of reached maximum potential in PT, but you still need guidance. We use those one-on-one sessions. And then for patients that really need a long-term guided program, they don't know what to do at the gym, we have another program called Lifestyle 365. And that's a monthly program where they are assessed monthly by Pat, our exercise physiologist, and they have it's whatever the patient's goals are at that point, whether they just want to be more healthy overall, if it's diabetes management, if it's, they have osteopenia, osteoporosis, and they need strength progression to stay healthy and reduce risk of injury, but don't know what to do at the gym. Then they meet with Pat, they get a monthly assessment, and she gives them exercises to help reach their goals that are appropriately prescribed exercises. And she tells them to come in 2 to 3 days a week. They use our facility, and they are basically doing those exercises on their own, but they are prescribed exercises.
Great. Yeah, I appreciate that. So there's a program that's done within the physical therapy plan of care that is prescribed exercise sessions with the exercise physiologist. There is a post-discharge, okay, you're not ready to commit to a full secondary program, but you still need further exercise progression beyond physical therapy that happens with the exercise physiologist. And those are one-on-one sessions. And then there's the actual, like the fitness program, the lifestyle program that is meant to be more of a month-to-month ongoing prescription progression type program with some data collection that occurs ongoing, related to that patient's plan and needs. Okay. That's great. So, and again, just things that don't exist in a typical PT clinic, right? Like your option after PT in most clinics is go home with your home exercise plan and keep doing this, or go join a gym and find someone else. Maybe I've got someone to hook you up with, but most of the time I don't. So that is, I mean, it's a different model than you guys were previously doing.
Yeah, I actually have a question too. The choice number one, where it's still within the PT plan of care, I'm trying to visualize that. How is that billed for? I guess I would just start with that. How is that billed?
So it's a cash pay service. All of the wellness services are cash. Yeah.
Okay.
Mhm.
And then can I assume that with option number three, where it's Lifestyle 365, if I remember correctly, is some of that also where then she'll actually get Pat will get clients from this, and where so some of these are just kind of coming in and she's helping design the program, but some of them they're coming in, they're actually training with her. Is that correct?
Yeah, so there's conditioning sessions, which are one-on-one, and those can be an extension of Bridge and the PT plan of care or independently. And the Lifestyle 365 is, the monthly membership program, and she is programming for all of those people, and they have their own thing going on. It has nothing to do with their PT, an active, like, current PT plan of care, usually.
Okay.
Yeah, so her clients have come as they're either discharged PT clients that have come on, but I think now that we're more established, we've got some word of mouth. So there's patients that have come in either as friends of other people that are in the program. We have other clinics in the area that have referred people to this program because they feel like they have, former patients that need ongoing care and guidance. So not all of them have been seen here as PT patients, and that's kind of how her program has grown.
And since I'm not familiar with like the size of your clinic and stuff like that, is there room for another Pat? Is it gonna get to the point where that's gonna be needed?
That's a great question, Jeff, because yes, and we just hired another exercise physiologist who will start in about a month, because we became so busy, that we need another Pat.
Yeah,
And there
good.
is
I
enough
love
space.
hearing it.
Yeah, we have very large space for considerably for most PT clinics, I would say.
Good.
For sure. And, I'm someone that spends enough time in your clinic to be able to speak on the space there too. It's great because it's an overlapping space, right? There's not a segregated PT space versus exercise space. Like there's a space where you probably wouldn't go if you're an exercise professional. Like you guys do have therapy tables in a certain spot, but outside of that, it's a shared clinic, man. Like everything's overlapping in there. So it's a really strong space for collaboration. And it's funny, I imagine that you guys on this call are thinking, wow, it's kind of funny that we're talking so much about the fitness side of this, but I think for context for you guys, I think a lot of the listeners to this probably they're people that are in the fitness side of this medical world trying to figure out how to get their foot in the door and really appreciate the context that you can provide about what is appealing to a physical therapist that would want to work with a fitness professional, and what's a model that would make sense for me to try to seek out, or a therapist that's talking the talk in a certain way that I could try to seek out. I actually think that some of the other people would be on the nutrition side. And what I know is that, you guys have a really strong referral system into nutrition. You've recruited a local provider who is just like, he's the man in terms of referring nutrition patients. But then you guys also have a pretty strong internal nutrition referral situation going on. I'd love it if one of you guys could help me understand, for you, like, just at a base level, explain to me how nutrition is related to outpatient physical therapy. Like, how do you use that? Or how do you have that conversation?
I think before we had this model, and even since, there are, I think the easiest explanation or example actually would be, I can't tell you how many times I've had patients mention their weight in particular. They come in, their knees hurt, their back hurt, their hip hurts, and they'll say something offhanded, you know, kind of like, oh, well, if I lost weight, that would be better. And, you know, before we kind of just had to agree, like, yeah, that probably would help, because we had no resource for that. There was like, yeah, you could lose weight, but I don't know who to refer to. So now that we have a dietitian, we can start that conversation and say, yeah, you know, you've mentioned this a few times. You've mentioned your weight a few times. You know, and trying to gauge where their readiness is for making a change. And referring them to our dietitian so that either that they can get that goal started, you know, whether it's directly related to their goals in PT. Sometimes it is, and sometimes it's not. But particularly for the patients with diabetes, getting them to understand how to actually properly manage that condition and have somebody in our corner who can help us and reinforce what we're trying to say. So I guess that's where I found the benefit is we have those conversations all the time, but not everybody has somebody to refer to. And we do. So
we also, there's a questionnaire that patients fill out as part of their initial paperwork that asks if they would be interested in meeting with the dietitian. And so if they've checked yes in that box, we as PTs get that paperwork as part of the initial evaluation paperwork. So we can open up that conversation if they don't, and it makes it easy because they've already said yes. Hey, I saw that you checked yes on this. Let's talk about that a little bit. And so that has made conversations. If the patient doesn't directly bring it up, that's another way that it's been easy to bring it up, is they've already checked yes.
Yeah, I actually do that on my assessment form as well, and for the exact same reason. I want to collaborate with nutritionists because I want to learn from them, and it's going to help me, and maybe we can, you know, pass patients or clients back and forth. But just like you just said, it also makes it really easy because they check the box. So now we have a conversation starter.
So many times too, we skirt around we have to like corral people into this conversation that we're kind of being sensitive about with regards to nutrition. And so it really is a lot of the time as easy as, are you interested in seeing a dietitian right now? Like, we actually capture more people through that mechanism than probably any other in most of our clinics. Is just, let's directly ask the question and just catch the people who are ready to make a change right now, who are already thinking about it, right? So yeah, Brandy, I agree with you though. And you know, my frustration in practice so often was, yeah, we have the conversation, but then what? Like, then what do I do with you? You're interested in making that change, but then I don't know if I have a resource that I can even send you to that's going to be able to serve you. And that's a really hopeless feeling in medicine when we're working with someone on a care plan for their health. It's so beneficial to have those people in-house that we trust in their work. So
and I'll add to that a little too, is it's not just, you know, we refer this person to her name's Laura, our dietitian. And she gives us feedback if it's relevant to PT. So we're not going in and reading all their nutrition notes, but if it's something that she feels is relevant to what we're doing, she'll tell us how things are going. So if it's not going well, or if something else came up that the patient didn't tell us, but it's important for us to know, like post-surgically, then it has helped kind of round out that communication. It also creates some accountability for the patient of, hey, I referred you to nutrition. Did you schedule that appointment? Did you complete that appointment? How did that appointment go? So it's not even like we refer and then we forget about it. It's a conversation we continue to have and follow up on.
What's great about that is, I think that extends to anytime you practice with other people beyond yourself. So any kind of this interdisciplinary care model is that's true. And Jessica can tell you right now that that's the case as a PTA, right? Like, and you guys know it. Jessica will see people and they'll tell her something way different than they told you. And
can I see everybody's patients? So I've got, I can just let everybody know. So
right. That's right. Yeah. And it's truly though, it's the benefit to it. And when we have different conversations with the same people in a different context, we end up learning so much more about what can help them. And we end up being that, that trusted place for them. When they can come somewhere and there's multiple people that they trust that can help them, makes a big difference. So I want to wrap up with a final question of advice from you guys for any group, or really any therapist, any exercise professional who's considering making a change to trying to do an interdisciplinary model like yours. What advice do you have, or what would you suggest for anyone trying to get started?
I'm gonna let Haley answer first.
I would say, stick with it. Stick with it. Keep learning. You don't know what you don't know. So seek out, people like Jeff Young, seek out people like Thomas Hammett, seek out the people that are doing it, find out what their experience is, find out what's helpful to them, and keep learning. I think that, we have monthly in-services in regards to lifestyle medicine, and I continue to learn every month. And so it's ever evolving and ever changing. And so I would say just stick with it. If you're interested in it, keep learning and find the right people to work with. And those are the biggest things.
I would agree with that. Change is always hard. Change is never easy, and there are always going to be things that make it seem impossible at first. And I will admit that I was on that train for a while. I was like, there's no way this is going to work. This takes too much time. We don't have time for this. But it had to reset every once in a while and just remember, like, yeah, any sort of change. We've gone through lots of changes, like EMR changes. We all know how horrible that is. This was this was just another minor blip, and now that you're over it, it's running smoothly. So
Jessica,
I actually agree 100% with everything that they just said. It's definitely, it was a process, and, I will agree that I was kind of on that, like, yeah, I don't know if this is going to work type thing. But it does work. You just have to kind of give it time and iron out all the, little issues and stuff. And you have to have the right people, and I think why it works so well here is because we have the right communication system and we have the right people who are trying to make it work. And I think we do a pretty good job of that. So that definitely matters.
Yeah, I'll just I know we have about a minute left and we have a hard cutoff here. So let me just wrap this up to say that first of all, I could sit here and listen to this stuff all day long. I really could. Yes, change, the learning curve. We all hate that initial learning curve, and we want to avoid it. And but the bigger picture is the health of the patient. And then if every clinic in the country operated like this one, then what the effect it would have on public health too. So that's kind of the way I look at it. And I got lucky because my first job out of college was at University Medical Center Diet and Fitness Center. So my first job, and it was integrated. So we had medical, we didn't have physical therapy, we had medical, nutrition, fitness, and behavior components. So my first job out of college was in an integrative experience, an atmosphere. And so that's part of the reason why I have the passion that I do. Would love to have you back here at some point, because the truth is I would like to then maybe switch over and I'll ask some of the questions, because now that I'm getting to know you better, I could definitely think of some questions like, what would you think if you saw me doing heavy deadlifts with your patients, at some point, and just some of those types of questions as well. Or maybe I'm not cueing as much as you think that I should, how would you address that? And, things like that. So yeah, I really appreciate this whole conversation. Hope that you're willing to come back, and I know you got to get going. So thanks so much, and hopefully we'll see you next time.
Thank you.
Thank you.
Appreciate you having us. Definitely would be interested in speaking again. So
do you need assistance in connecting with a fitness professional in your local area or virtually to add this connection to your patient services? If so, please email mrfinstitute.org@gmail.com. Please also remember to check out mrfinstitute.org for information on how to learn more about the education we offer and to stay current with our podcast series. If you're interested in implementing the services discussed in this episode, email us for more information. We'd be more than happy to help. Thanks for tuning in, and we'll see you in the next episode.